laparoscopic ventral hernia repair as performed by Dr. Agbola. This method is a two-port technique of repair. The primary port for access is placed at the palmar point. This is a safe entry point for ventral hernias, which is just about 2 cm below the costal margin in the mid-clavicular line. A 10 mm port for the telescope is placed at this point, perpendicularly to the patient's supine, and once inside, an initial diagnostic laparoscopy is done to view the site of hernia to assess the level of adhesions. A second port is thereafter placed about 7.5 cm inferior and lateral to the telescope port. A 5 mm port is placed at this point where a working instrument can be used. For a two-port technique, cosmesis is the aim. Now the hernia has been reduced, as you have seen, and suture is being passed with the aid of a suture passer. Now the telescope has been changed to a 5 mm port, while the mesh is being introduced through the 10 mm port at the palmar point. You see that the field has changed because now we're using a 5 mm telescope to view the surgery. Now you see the suture is being retrieved by the suture passer towards the initial angle, which is on the other side diagonally opposite the telescope, and the mesh is gradually being unfolded. Suture has been taken out using the suture passer, and a knot will be made outside, right over the skin. A small stab incision would have been made through the skin before passing the suture passer, such that the suture will stay in the subcutaneous tissues. Now the suture passer is taken to retrieve the second limb of the first suture, which will now be taken out at another point distal to the initial point of entry to ensure a proper knot is made that would fix the mesh to the anterior abdominal wall. Now that first knot has been made and is fixed. The suture passer is coming through another angle to pick the first of 3 sutures that had initially been tied to the angles of the mesh to facilitate the use of a one-port technique. Now the second suture will soon be made, and surgery will soon be over. You see, for the surgeon who is practicing the two-port technique, take your time. You may be using 2-3 hours initially, but very soon you will be able to perform the surgery within 60 to 90 minutes as you get used to it. Now the suture passer will soon be passed through the third angle, yes, closer to the telescope to the right of the patient. Okay, that will be made, and before you know it, the whole mesh will be fixed onto the abdominal wall, and tackers will be used to make an inner crown. This is one of the techniques of ventral hernia repair, and it's good if you can practice it. It's gives a better cosmetic outcome compared to the 3-port technique. So the final suture is about to be taken by suture passer to make the final note. Okay, down below there is no bleeding, and hopefully there has been no intestinal perforation. At the end of the surgery, the surgeon must take time to observe and watch out for any bleeding or injury to the bowel. Alright, so the mesh is in place, and one must ensure that there's no pocket for momentum to hide between the mesh and the now, there's no bleeding below. The mesh is above. At this point, the telescope light is down so that the surgeon can view superiorly. Right, you see, now that's a tacker. An assistant is putting hand above the abdomen to ensure that the tacker is at right angle to the abdominal wall. The tacker being used here is ProTack and does a good job for the inner crown in fixing. Ensure when you are fixing the mesh that the tack is not placed within the hernia defect, otherwise it may catch the skin and it may cause discomfort. It must be fixed around the edge of the hernia, forming an inner crown to reinforce the sutures that have been placed at the edges.